next topic we'll cover now is central anti-epileptic drugs in CNS. Now epilepsy, we all know it is characterized by seizures. Seizure is abnormal electrical discharge in the brain. So in simple language, seizure is due to overstimulation of neurons. So that means if we want to treat the seizure, we have to depress the brain. So if we depress the brain, we can treat epilepsy. And how to depress the brain? So one simple method is, if we inhibit the brain, we will like to increase the inhibitory amino acid of brain. What is the major inhibitory amino acid in the brain? Yeah, it is GABA. So if a drug increase GABAergic activity, it can depress the brain. Similarly, what is the major stimulatory amino acid in brain? So it is glutamate. So if a drug decrease the activity of glutamate, it can depress the brain. Then two channels which cause stimulation or depolarization at most of the places. These are calcium channels and sodium channels. So if a drug inhibit calcium or sodium channel, it can depress the brain. And one last new mechanism which has been recently formed, if a drug open the potassium channels in the neurons, it can depress the brain. So 5 major mechanisms by which an anti-epileptic drug can work. Drug may increase GABA, drug may decrease the activity of glutamate, drug may block sodium channels or calcium channels, and the drug may open the potassium channels. So we'll discuss these one by one, starting with the number 1, drug increasing the GABAergic activity. First of all, we need to understand how GABA is produced and works. Then we can discuss how we can increase the activity of GABA. So GABA is produced and stored here. When nerve impulse comes, GABA is released in the synapse. Then it work on the channels. Remember chloride channels we discussed? So GABA open the chloride channels, that will depress the brain. Now we need to stop the action of GABA, and the action of GABA can be stopped by either metabolism, and GABA is metabolized by an enzyme called GABA transaminase. Or we can stop the action by reuptake. So GABA can go back into the vesicle, the action stops, and the transporter which help in reuptake of GABA is called GABA transporter 1, or in short GAT1. So in epilepsy, we want to increase the activity of GABA. For increasing the activity of GABA, we have to increase the GABA at this place. So what are the options by which we can increase the GABAergic activity? First thing we can do is, we can give a drug which release GABA. If more GABA is released, brain will be depressed. We can use the drug in epilepsy. Number 2, we can inhibit the metabolism of GABA. If GABA is not broken, more GABA, so it will depress the brain. Number 3, we can inhibit the reuptake of GABA. If GABA is not transported back, it will stay in the synapse, so then it can depress the brain. And lastly, we can give a drug which directly open the channels. So even without GABA, they can depress the brain. So 4 type of drugs we can use: drug releasing GABA, drug inhibiting metabolism, drug inhibiting reuptake, and drug acting on channels. So one by one we will cover these drugs, starting with the drug releasing GABA. Drugs which act by releasing GABA are pregabalin and gabapentin. Pregabalin and gabapentin, these act by releasing GABA. Now important point about these drugs to remember, that apart from epilepsy, their major clinical use is they are drug of choice for neuropathic pains. They are drug of choice for neuropathic pains. Particularly, they are drug of choice for neuropathic pain due to diabetic neuropathy, and they are drug of choice for post-herpetic neuralgia. diabetic neuropathy, and post-herpetic neuralgia. Gabapentin and pregabalin are drug of choice. Now, recent studies suggest that these drugs may act by blocking the calcium channels. Although till now it is considered that their major mechanism is to release GABA, but nowadays it is assumed that they mainly act by blocking the calcium channels. Then second thing we can do is we can inhibit the GABA transaminase enzyme. So if we inhibit this enzyme, GABA will not be broken. So more GABA and brain will be depressed. And the drug which acts by inhibiting the GABA transaminase enzyme is, number 2 drug is vigabatrin. Vigabatrin. Now vigabatrin, the mechanism is written in the name of the drug itself. The name says it is GABA transaminase inhibitor. The name says the mechanism GABA transaminase inhibitor. And this name also tells its major side effect. The main side effect of vigabatrin is visual field defects. So it starts with VI. So VI is used to remember. It causes visual field contraction. Vigabatrin can cause visual field contraction. And from the name you can also remember the use of vigabatrin. If the adverse effect is at the beginning, the use should be at the last. So the last 2 letters of the drug, which is in, it stands for infantile spasms. So vigabatrin is used for treatment of infantile spasms. Another question asked is, what is the drug of choice for treatment of infantile spasms? So if the question is asked on drug of choice, then drug of choice is ACTH. Vigabatrin can be used, but the drug of choice is adrenal corticotropic hormone. Read carefully. If the question is asked drug of choice for infantile spasms, nothing else is mentioned, only infantile spasm, then the answer is ACTH. But on the other hand, if the question is asked drug of choice for infantile spasm in a patient of tuberous sclerosis, if the person is having tuberous sclerosis, then in these patients, drug of choice for infantile spasms is vigabatrin. So read carefully, only infantile spasm ACTH, but infantile spasms associated with the tuberous sclerosis, the drug of choice is vigabatrin. Okay. Number 3 we can do is we can inhibit the reuptake of GABA. And the drug which acts by inhibiting the reuptake of GABA is tiagabin. Tiagabin. It inhibits the reuptake of GABA. And again from the name, you can remember the mechanism. The tiagabin name says that it is T means transport, I means inhibitor, and this AGAB is GABA. So it is transport inhibitor of GABA. So tiagabin acts by inhibiting the transport of GABA, that means reuptake of GABA. And from the name you can also remember which transporter it is inhibiting. It is inhibiting GAT1 transporter, and in the name it is written it inhibits G, A, T and I look like 1, so GAT1. So it acts by inhibiting the GABA transporter 1. Now lastly, we can give a drug which acts on the channels, and we discussed the drugs acting on the channels are, barbiturates and benzodiazepines. Barbiturates and benzodiazepines. The main barbiturate used in epilepsy is phenobarbital, whereas main benzodiazepine used in epilepsy are diazepam, lorazepam, clonazepam and clobazam. These are the benzodiazepines used in epilepsy. Now important points regarding these to remember. Phenobarbital, if it is used in children, it can cause hyperkinesia. The question is asked, which anti-epileptic drug can cause hyperkinesia in children? It is phenobarbital. Then benzodiazepines, diazepam is a drug of choice for febrile seizures. Diazepam is a drug of choice for febrile seizures. Lorazepam is drug of choice for status epilepticus. Status epilepticus, drug of choice is lorazepam. Clonazepam, it is useful in absence seizures, although not the drug of choice, useful in absence seizures. Very few drugs are effective in absence seizures. Clonazepam is one of them. And clobazam is recently approved for a syndrome called Lennox-Gastaut syndrome. Clobazam is used in Lennox-Gastaut syndrome, not the drug of choice, used in Lennox-Gastaut syndrome. So these are the important drugs which act by increasing the GABAergic activity, the first mechanism in treatment of epilepsy. Now, second method of treating epilepsy is we can decrease the activity of glutamate. Glutamate is the main stimulatory amino acid in brain. Now, the two main receptors by which glutamate works, one receptor is called NMDA and second receptor is AMPA receptor, AMPA. So, if we block any of these receptors, we can use the drug for epilepsy. So, we have two types of drugs. One is NMDA blocker and the second is AMPA blocker. The drug which acts by blocking NMDA receptor is felbamate. Felbamate is not commonly used because of its very important side effects, and that side effect is bone marrow suppression. Felbamate causes bone marrow suppression. Because of this side effect, it is not a preferred drug, and this side effect you can remember from the name itself. Its name says B for bone, M for marrow, bone marrow. It eats the bone marrow ate. So felbamate is ate the bone marrow. So we do not like to use this drug. On the other hand, very recently a new drug has been formed which acts by inhibiting the AMPA receptors, and this drug is called perampanel. You can remember from the name itself, its name says it is making the AMPA receptor of glutamate nil. That means AMPA is not able to work. Perampanel. It is a new drug which is indicated in focal seizures. The second method of treating the epilepsy is to decrease the activity of glutamate. We can give a drug that block calcium channels. Now, calcium channel in the thalamus or in the CNS, they are mainly of T types. So if a drug block T type calcium channel, it can be used in epilepsy. And the drug which acts by blocking this type of calcium channel is ethosuximide. Now, special things to remember about ethosuximide is, it is used only for absence seizure. It is a narrow spectrum anti-epileptic drug. It is used only for absence seizures. It is a narrow spectrum drug. It is not effective in any other seizure. So it is a first line drug for absence seizures. But if absence seizures are associated with subclinical other seizures, then ethosuximide is not preferred because it cannot treat other seizures. So ethosuximide only for absence seizures, not for any other seizure. Then the next mechanism is to block the sodium channels. Now, large number of drugs can act by blocking the sodium channels. These include phenytoin, carbamazepine, drug related to carbamazepine is oxcarbazepine, similar drug. Then we have topiramate, zonisamide, lacosamide, and rufinamide. So the different drugs which act by blocking the sodium channels. The important point regarding these drugs to remember: lacosamide and rufinamide, these are the new drugs which is which are used in focal seizures. Topiramate and zonisamide. These drugs can cause renal stones. Which anti-epileptic drug can cause kidney stones? It is topiramate and zonisamide, because these drugs have carbonic anhydrase inhibitory activity also. Because of that activity, the urine become alkaline, which can result in renal stones. Now, topiramate, in addition, it has many other uses. So, topiramate is recently approved for many indications. The important uses of topiramate, apart from epilepsy, are: it is used to decrease craving of alcohol. The uses of topiramate: it decreases craving for alcohol. Topiramate is the only anti-epileptic drug which causes weight loss. So it is approved recently for treatment of obesity also. Topiramate is also approved for migraine prophylaxis of migraine. Then topiramate is also used in bipolar disorder. So topiramate used for decreasing the alcohol craving, for obesity, for migraine, and for bipolar disorder. So topiramate used for these 4 indications apart from epilepsy. And again, you can remember from the name. In Hindi you will study, the name start with the topi. Topi means cap. So if a person has worn the cap, अगर टोपी पहनी है, तो there is no requirement of comb. So topiramate, it will be useful for comb, craving of alcohol, obesity, migraine, and bipolar disorder. So we discussed about topiramate and zonisamide. The next drug are carbamazepine and phenytoin-like drugs. The special point about these drugs to remember: these drugs are contraindicated in absence and myoclonic seizures. They can precipitate absence and myoclonic seizures. So these are contraindicated in absence and myoclonic seizures. These are useful in generalized tonic-clonic seizures and focal seizures. Generalized tonic-clonic and focal seizures, they are useful, but absence and myoclonic seizure, they are contraindicated. Now regarding carbamazepine group of drugs, carbamazepine, it is drug of choice for focal seizures. Carbamazepine is drug of choice for focal seizures, and it is also drug of choice for trigeminal neuralgia. Carbamazepine is a drug of choice for focal seizures and trigeminal neuralgia. Then there are 2 more indications where carbamazepine can be used, but it is not the drug of choice. Carbamazepine can be used for diabetes insipidus and bipolar disorder. Carbamazepine can be used for diabetes insipidus and bipolar disorder, but it is not the drug of choice. Drug of choice for diabetes insipidus is desmopressin, and drug of choice for bipolar disorder is lithium. Carbamazepine can be used for both the indications, but drug of choice are different. Major adverse effect we can remember as 4 A's. First A is auto-induction of metabolism. We know carbamazepine is powerful enzyme inducer. It increases the metabolism of many drugs. It also induces its own metabolism. So when its own metabolism is increased, then its effect will decrease. So we have to start carbamazepine at a lower dose, but we need to increase the dose in few days because of auto-induction of metabolism. So this can result in tolerance. Then second A is aplastic anemia. So basically carbamazepine cause bone marrow suppression, and this bone marrow suppressant activity can result in anemia, leukopenia, thrombocytopenia. These side effects can occur. Then third A is it causes release of ADH from the posterior pituitary. Carbamazepine releases ADH from the posterior pituitary, and this release of ADH, it can result in SIADH as a side effect. Now, what is the function of ADH? To retain water or to retain sodium and water? Yes, ADH retain only water. So when ADH is released more than required, then only water will be retained. And when only water is retained, it will lead to dilution of all the ions. And most clinically significant is sodium. So that can result in dilutional hyponatremia. Very important side effect of carbamazepine, dilutional hyponatremia. And the chances of this is high in elderly people. So carbamazepine is avoided in elderly people because of high risk of hyponatremia. So carbamazepine, we discussed, it is drug of choice for focal seizures, but drug of choice for focal seizure in elderly is not carbamazepine. In elderly, the drug of choice for focal seizures is lamotrigine. All other patients, it is carbamazepine. So carbamazepine can cause release of ADH. Then last A you can remember A for ataxia, nystagmus and vertigo. So many anti-epileptic drugs, they can result in cerebellar symptoms like ataxia, nystagmus and vertigo, and carbamazepine can also cause this adverse effect. This is mainly seen in overdose. Clear? Now in this group we are left with one drug, the most important drug, it is phenytoin. Phenytoin. The important points about phenytoin we have to discuss. First of all, important points regarding the pharmacokinetics of phenytoin. Phenytoin is a drug which follows zero order kinetics. Remember we discussed 0 watt power, P for phenytoin. Second, phenytoin is a powerful enzyme inducer. So it has a lot of drug interaction, enzyme inducer. Then phenytoin, it is used for antiarrhythmic action also. Remember, phenytoin belongs to class 1B antiarrhythmic drugs. It is used for treatment of arrhythmias. Next, phenytoin we just discussed, it is useful in generalized tonic-clonic seizures and focal seizures, but it is contraindicated in absence and myoclonic seizures. Contraindicated in absence and myoclonic seizures. So these are the points which we have already covered. But important to remember here, phenytoin has many adverse effects. So very commonly these are asked in the exams. What are the adverse effects of phenytoin? And the adverse effects of phenytoin you can remember from the mnemonic hot malika. Adverse effects of phenytoin you can remember from hot malika. H stand for hirsutism. Hirsutism. Another on H is hypertrophy of gums. Gum hypertrophy and hirsutism. Then O for osteomalacia. Phenytoin can result in osteomalacia by causing vitamin D deficiency. Then T means teratogenicity. Phenytoin is teratogenic. If we give phenytoin during pregnancy, the baby may develop a malformation called as fetal hydantoin syndrome. So phenytoin use in pregnancy is associated with fetal hydantoin syndrome. Then M for megaloblastic anemia. Phenytoin causes deficiency of folic acid, and this folic acid deficiency can result in megaloblastic anemia. Then A for arrhythmias. We know phenytoin is antiarrhythmic drug, and any antiarrhythmic drug in overdose can cause arrhythmia. So special to remember about this side effect. This side effect is seen only in overdose, whereas other side effects can be seen at normal plasma concentration, but arrhythmia will be seen in overdose only. Then L for lymphadenopathy, lymph node enlargement. Then I for deficiency of insulin. So phenytoin can result in hyperglycemia by causing deficiency of insulin. K for vitamin K deficiency. Phenytoin can result in deficiency of vitamin K. We know vitamin K is involved in clotting. So when vitamin K is not formed, it will decrease the clotting, that can increase the risk of hemorrhage or bleeding, and this side effect is particularly important in pregnancy. So whenever phenytoin is given in pregnancy, there may be two risks. One, phenytoin can result in congenital malformations. If that is not seen, teratogenicity is not seen, the second risk, at the time of delivery, there is very high risk of hemorrhagic disease of newborn, because vitamin K will be lesser. So whenever phenytoin is given during pregnancy, at the time of delivery, the baby must be supplemented with vitamin K to prevent the hemorrhagic disease of newborn. Okay. Then A for ataxia, nystagmus, vertigo. These are the symptoms of which organ? Yes, these are cerebellar symptoms. So phenytoin can cause cerebellar dysfunction also, but again these side effects are seen only in overdose. They are not seen at normal dose. So you can remember in the mnemonic hot malika, the two A's, A stand for acute side effect. So they will be seen when there is acutely overdose of phenytoin. Whereas all other side effects are seen at normal dose on long-term use. Whereas arrhythmias and cerebellar dysfunctions can be seen with acute overdose. So these are the important points regarding the phenytoin. So we covered the number 4 mechanism, that means sodium channel blockers. Now the last mechanism is potassium channel opener. Recently a new drug has been approved which is potassium channel opener, and the name of the drug is retigabin. Retigabin. Another name of the same drug is ezogabine. Retigabin or ezogabine are same drug. They are they are acting by opening the potassium channels, and these are indicated in treatment of focal seizures. This is a new drug for focal seizures. And important thing to remember, their name contains GABA, but it does not act on GABA. So likely to be asked in the exams, it is name contain GABA but does not act on GABA, because actually the name do not contain GABA, the name contains GABI. So these are the important points regarding the anti-epileptic drugs. Now we have covered almost all the drugs, all the mechanisms we have covered, but we missed the important drugs. Two important drugs which we missed. One is sodium valproate and second is lamotrigine. We did not forget these drugs. We intentionally left them because they have multiple mechanisms of action. Valproate, it has first 4 mechanisms. That means it is a sodium channel blocker. It is blocker of calcium channel also. It increase the activity of GABA as well as it decrease the activity of glutamate. So all the 4 mechanisms were present in valproate. Now because it has almost all the mechanisms, so it is a very broad spectrum anti-epileptic drug. Very broad spectrum. In fact, valproate is a drug of choice for most of the seizures. So most of the seizures including valproate is a drug of choice for generalized tonic-clonic seizures. It is also drug of choice for absence seizures. It is also drug of choice for myoclonic seizures, atonic seizures, and it is also drug of choice for Lennox-Gastaut syndrome. So valproate is drug of choice for majority of the seizures. Apart from seizures, valproate is also very important drug for bipolar disorder. Bipolar disorder. Major adverse effects of valproate you can remember from valproate itself. V stand for vomiting. So almost any drug can cause vomiting, so is valproate. A for alopecia. So valproate in particular, it can cause two adverse effects on the hair. Some people develop alopecia and some people develop curling of hair. Valproate can lead to alopecia or curling of hair as an adverse effect. Then L is liver. Valproate is hepatotoxic. Very important side effect of valproate. It is hepatotoxic, and this side effect is more important in young children. In young children, the risk of hepatotoxicity is very high. Then P, we have two important things on P. One is pancreatitis. Valproate can predispose to pancreatitis. And second on the P is it can increase the risk of polycystic ovarian disease. Valproate can increase the risk of polycystic ovarian disease. Sometimes the question is asked, which is the gender specific side effect of valproate? So answer is PCOD. Obviously, the PCOD will never be seen in males, so it is specific to females. So gender specific side effect of valproate is PCOD. Then R means rash. Valproate can cause skin rash, it can cause allergy, any drug can cause allergy, even valproate can cause. Then O is obesity. Like most of the anti-epileptic drugs, valproate can cause weight gain. Obesity can occur. Then A is ataxia. So like phenytoin and carbamazepine, valproate in overdose again can cause cerebellar dysfunction, which can lead to ataxia, nystagmus and vertigo. And lastly, TE means teratogenic. Valproate is the most teratogenic anti-epileptic drug. So whenever valproate is given during pregnancy, we must supplement high dose of folic acid. That means 4000 microgram per day folic acid must be given to prevent the neural tube defects. So these are the major adverse effects of valproate. Now regarding lamotrigine, lamotrigine also has multiple mechanisms. It acts by blocking sodium channel. It acts by increasing the activity of GABA. It acts by decreasing the activity of glutamate. So multiple mechanisms are there. But lamotrigine, it has a very important adverse effect, which is called Stevens-Johnson syndrome, or even toxic epidermal necrolysis. So these are basically the skin side effects in which there is sloughing of skin. So Stevens-Johnson syndrome, when the skin area involved is less than 30%, whereas toxic epidermal necrolysis when it is more than 30%. So these are very serious side effects of lamotrigine. Initially, they were assumed to be very common, but the new studies show that they are not that common. But because of risk of these, lamotrigine is still used very cautiously. But lamotrigine, as we discussed earlier, it is a drug of choice for focal seizure in elderly. In other patients, we mostly prefer carbamazepine, but in elderly, lamotrigine is a drug of choice for focal seizures. Clear? Now we will move to some new drugs in epilepsy. New drugs. One of the new drugs which act on SV2A. First of all, what is SV2A? We know that this is the synapse, this is the vesicle. Neurotransmitters are stored in the vesicle. When the nerve impulse comes, the neurotransmitter has to be released in the synapse. On the synaptic side of the vesicle here, a protein is present which is called as SV2A. SV2A is synaptic vesicular protein. So some drugs, they bind to this protein, and those drugs are levetiracetam and brivaracetam. levetiracetam and brivaracetam, they bind to SV2A and then they can modify the release of neurotransmitters which can be used in epilepsy. So levetiracetam and brivaracetam, they bind to SV2A. Okay? So this is first group of new drugs in epilepsy. Then we have another new drug which is very recently approved in epilepsy. It is called as cannabidiol. Cannabidiol. So as the name tells, it acts by stimulating the cannabinoid receptors. So cannabinoid receptor, there is CV1 receptor in the body. It acts by stimulating cannabinoid receptor. But special point to remember, this is the first compound which is directly obtained from cannabis plant. Other drugs are synthesized, but it is directly obtained from cannabis plant and it is used to treat Dravet syndrome. Cannabidiol is approved for treatment of Dravet syndrome seen in children, in which there are multiple types of epilepsies. So cannabidiol is approved for Dravet syndrome. Then another new drug which has been approved recently is tiripentol. This drug, it also acts by GABA receptors by increasing the action of GABA. But one more mechanism is proposed, that it acts by inhibiting the enzyme lactate dehydrogenase. This tiripentol is also approved for treatment of Dravet syndrome. So two drugs have been approved recently for Dravet syndrome. One is cannabidiol and second is tiripentol. So these are the new drugs which are used in epilepsy. Now here important thing to remember, one is epilepsy in pregnancy. Second is seizures in eclampsia. Remember, these are not same. Eclampsia means the seizures are occurring. These are acute episode of seizure in pregnancy due to high blood pressure. So when the seizures are already occurring, we need to control the seizures by giving the intravenous agents. For eclampsia, the drug of choice is magnesium sulfate. It is given intravenously. And magnesium sulfate, it causes neuronal protection in the baby also. So it is a drug of choice. On the other hand, when we talk about epilepsy in pregnancy, we mean that seizures are not occurring now, but we want to prevent the seizures. So that means we have to give the drug throughout pregnancy for 9 months to prevent the seizures. So here we will give oral drugs, number one. And number two, here we are more concerned with the teratogenicity. So first of all, the most teratogenic anti-epileptic drug is valproate, whereas the least teratogenic anti-epileptic drug are lamotrigine and levetiracetam. They are least teratogenic, and from the name itself you can remember valproate is very much teratogenic. V for valproate, V for very much teratogenic. Whereas L for lamotrigine, L for levetiracetam, L for least teratogenic. But there are two types of questions asked for epilepsy in pregnancy. The first is, a female is pregnant, but she is already taking some anti-epileptic drugs since 2 years, 3 years, and the seizures are well controlled. So when this female comes to you with pregnancy, so what will be the advice given? Remember, if the female is already controlled on some anti-epileptic drug, we will not change that drug, because when we change the drug, there is risk of seizures, and if the seizure occur, that will be very much harmful, not only for the baby but also for the mother. So due to this reason, if the female is already taking any anti-epileptic drug, even if it is valproate, we will not change. We will continue same drug. Only important thing is we will add the high dose folic acid. That means 4000 microgram folic acid per day to prevent the teratogenic effects. Okay? Second question asked, a female is pregnant and the seizure occur first time in pregnancy, so what will be the drug of choice? So obviously, if we are first time wanting to give the drug, we will give the safest drug, so that will be lamotrigine or levetiracetam. So lamotrigine or levetiracetam are drug of choice for epilepsy in pregnancy. Okay, so these are the important points regarding the anti-epileptic drugs. Okay.